Good afternoon. I'm Barbara McLean, and welcome to Group 6 of the Rise Up Critical Care course. And this is Cardiac Rhythms number 4. So happy that you're here with me today, and I hope we'll learn something together. Thank you. So to begin, our salient points so far. Remember, persistent tachycardia is always a warning sign of compensation. So check your patient for pain, agitation, high fever, and to see if that is compensatory for tissue hypoxia. That means with persistent tachycardia, make sure that you don't have metabolic acidosis. When the heart beats more rapidly, there's less time for the ventricles to fill, and therefore the amount of volume that is ejected by the heart may be lessened. Persistent tachycardia is always a cause for concern, and bradycardia with hypotension is always abnormal. Salient points so far, number 2. There are 2 major groups of electrical cells, the primary, secondary, and tertiary pacemaker cells in the pacemaker tree. That would be the sinus node, the AV junction, and the Purkinje fibers. But any cell in the myocardial mass can reach threshold first. Reaching threshold means that you open your gates. The gates in the atrial cells are potassium and calcium dependent for depolarization, and the gates in the ventricular cells are potassium and sodium dependent for depolarization. That's why for atrial tachydysrhythmias, we use first of all a sympatholytic beta block, potassium and calcium channel antagonists, and for ventricular tachydysrhythms, those rhythms respond to potassium and sodium antagonists. When we have heart block, it's always important to remember that first degree, prolonged PR interval, and second degree type 1, prolonged PR interval until you have a P wave that is not conducted, is disease within the AV junction itself. Second degree Mobitz type 2 and third degree heart block usually occurs at the common bundle of His or below that, and it tends to be an infarctive disorder. First degree block is associated with increased risk for atrial fibrillation, might require pacemaker implementation, and actually contributes to all-cause mortality. Second degree heart block, if you have 2 or more non-conductive P waves before each QRS, you should be thinking urgently about a pacemaker. That's indicated for advanced second degree or third degree heart block. And reversible causes of complete heart block include some of our medications, in particular beta block therapy, and also with Lyme disease. Heart blocks above the His bundle tend to be more stable. Heart blocks below the His bundle tend to be more unstable and require consideration for pacing. Salient points so far. V1 and V2 give us the best view of the right ventricle. And remember, current should go away from the right ventricle. V5 and V6 actually give us the best view of the left ventricle. And remember, current should be going towards the left to the left ventricle. Look for the RR pattern in these pair of leads. Incomplete bundle branch block meets the morphology pattern, but the width is less than 1/20 seconds. And also to remember that when we have hemiblocks, those are partial blocks, and that's a little beyond what we're doing in this class so far, but hemiblocks give us a change in the axis in relationship to the bundle branch blocks. Right bundle branch block looks for an M in the right-sided leads and a W in the left. Remember William Morrow. Left bundle branch block looks for a W in right-sided leads and an M in the left. And that's the morphology shape that tells you about dysynchronous activation of the ventricles. So we move to pacing as a therapeutic intervention for any of our blocks that cause significant and profound dysfunction. So whenever we have symptomatic bradycardia, if we have sinus arrest, we have sinus exit block, we have AV nodal conduction system dysfunction, that's the number 1 reason for pacing. And if we have drug-induced bradycardia where we might do temporary pacing to get us through the period of time to clear the medication from our blood. So we look at that symptomatic bradycardia, we look at symptomatic heart blocks, we think about bifascicular, which would mean right bundle and left anterior, right bundle and left posterior, or trifascicular blocks, right bundle, left anterior, and a left posterior, which would be a complete heart block, but also trifascicular with first degree block, and then right bundle branch block and LAH. Sick sinus syndrome, where you actually have tachybrady syndromes that are somewhat related to breathing, but not like a sinus arrhythmia. Neurocardiogenic syncope, hypertrophic cardiomyopathy, cardiac support for any arrhythmia that actually is going to ultimately require ablation or medications that result in bradycardia, pacing, overdrive pacing, that's part of the ICD, overdrive pacing to fire at a rate higher than the tachydysrhythmia to gather back control of the heart, and of course for cardiac resynchronization therapy, which we perform in patients with chronic heart failure, and that's biventricular pacing, both ventricles actually being paced at the same time, so you don't have that dysynchronous activation. Patients who have class 4 heart failure cannot afford to have dysynchronous ventricular pacing because it so limits their cardiac ejection. All right, so what kinds of pacemakers can we use? There's two that are the most common for folks outside of a cardiac unit, outside of a cardiac surgical unit, and that would be temporary transvenous pacing or transcutaneous pacing. We can also pace the epicardium, and that we tend to do after cardiac surgery with an AV sequential pacemaker. And then permanent pacemaking allows us to do both single chamber, dual chamber, meaning AV, and biventricular. And then remember, anti-tachycardic pacing or rate adaptive pacing. Rate adaptive pacing is beyond the course that we are doing now. So, we think about our pacemaker. Our pacemaker has a beautiful generator. That's the mind of the pacemaker. That's connected to leads that are embedded into the ventricular myocardium. And we have three capabilities with our pacemaker. We have the capability to pace, which means the pacemaker from the generator sends along the lead wire to the ventricle or atria a stimulus that actually mimics the stimulus of the P wave or the QRS. It's the initiation of the electrical signal that captures the heart. That's identified by the pacemaker spike, just the pacemaker spike. So we look at spike to spike in the atria or spike to spike in the ventricle to tell us about the pacing function. The electrical spike can be sent down the lead wire into the ventricle or into the atria, but it must capture the chamber. Capturing the chamber means that you have a pacing spike that is followed by a waveform. The pacing spike is followed by a waveform. The ability of the pacemaker to depolarize the chamber is identified by the spike that is immediately followed by a waveform. So, if we are pacing the atria, the spike will be followed immediately by a P wave. And if we are pacing the ventricle, the spike will be immediately followed by a QRS. That's known as capture. Sense is an integral capability of our pacemaker to recognize and respond to the patient's own cardiac depolarization. In other words, there's an impulse that fires endogenously inside the patient, not from the pacemaker, to capture the atria. We see a normal P wave, and that P wave occurs before the time cycle for the next pacing spike. So what happens is, in that backwards communication to the pulse generator of the pacemaker sees the patient's own rhythm and resets its cadence to actually fire at the next window time. The ability of our pacemaker to recognize and respond to intrinsic cardiac depolarization and limit the firing of impulse. Gorgeous and so intelligent. So, some very specific principles of pacing. We're just going to look at a 3-letter code. There's actually 5 codes, but for our purposes, we'll only look at 3. Pacing is the first issue that we think of. And in 3 columns, we'll start with the pace column. And the letter, first letter in that column, tells us about the chamber paced. So if the letter is a V, the ventricle is paced. If the letter is an A, the atrium is paced. If the letter is a D, both atria and ventricle are paced. And if the letter is a 0, an O, that means no chamber is paced. Okay, well that's pretty good, but you always have to wonder if it says, oh, no chamber's being paced, that's kind of a strange thing, and we never actually have that when we talk about a pacemaker. The next thing is what chambers are sensed. So again, the same. Ventricular chamber, V, atrial chamber, A and V, dual chamber, and 0, none. Now we do often have pacemakers that are D for pacing and O for sensing, meaning that we have a pacemaker that is not sensitive to the patient's own endogenous rhythm. Third column is the sensed response. So the sensed response means that when the pacemaker generator senses that the patient has their own depolarization, it will either trigger the pacing or it will inhibit the pacing. Now, that's only particular, the trigger is really only particular to the atrial pacemaker. So if my patient fires his own P wave, a certain interval of time will be waited before the pacemaker will fire stimulus to the ventricle. If the patient himself cannot conduct the impulse from the atria to the ventricle, the P wave that the patient has will trigger the pacing spike to the ventricle. Inhibition means that we recognize that the patient has had his own endogenous rate, his own endogenous P wave or own endogenous QRS, and inhibits the pace fire. That means that if I have both trigger and inhibition, that would be dual. And then, of course, none. So the most common form of pacing is D, D, D. Dual pacing, dual sensing, and dual response. So both AV paced, AV sensed, and triggering plus inhibition. So commonly used modes, AAI, that means the atria is paced, the atria is sensed, and if the patient has his own P wave, then we will inhibit the firing from the pacemaker. So pace, sense, response. VVI, can you guess? Absolutely. Ventricular paced, ventricular sensed, and inhibited when the patient has his own endogenous QRS. DDD, which is an atrioventricular pacemaker, demand, sensed, and inhibited and triggered. So that's very important. And last, AOO, atrial asynchronous pacing, or DOO, dual chamber asynchronous pacing. Okay, so let's start. One of the most important things that we do is we sense the pacer spikes. We have to evaluate those pacer spikes. So on this EKG strip, what you are actually seeing is a P to P to P to P interval that we're going to stop. I want to redo this one, I'm sorry. Okay. So 3, 2, 1. So with this slide, what we're going to do is identify the automatic pacing interval. That's the pacing rate that's been set on the pacemaker generator. So the pacing rate is when we evaluate 2 consecutive pacemaker spikes. So first 2 beats, we can see spike to QRS, spike to QRS. Then we have a spike and we have another QRS. Very important to actually look at our patient to evaluate this as appropriate. So spike to spike to spike to spike. And you might not have realized that this spike was firing basically on time. So this is spikes that appear regularly unless the pacemaker is inhibited by sensed intrinsic activity. Now the principles of capture, which really correlate to spike interval. The principles of capture is that we have to set a level of electrical impulse. That is typically referred to as milliamps, or it can be actually talked about as millivolts, which basically are the same thing. Milliamps, typical atrial MA milliamps is 5, and typical ventricular milliamps are 8 to 10. Now all that is a measurement of the signal, but we like to talk about it in a more specific manner, which could be the millivolts. Okay, so atrial and ventricular sensitivity in millivolts, that, again, I'm sorry. 3, 2, 1. Principles of capture. And there are two really particular ones that are important. First of all, the output, which is the amount of stimulus that I'm delivering into the chamber. Typical for the atria to be at 5 milliamps, and typical for the ventricular impulse from the pacemaker to be at 8 to 10 milliamps. And now I want to drop down to the atrial and ventricular sensitivity. So that changes. That's not measured in milliamps, that's measured in millivolts. And the millivolts are actually the height of the signal that gets sensed by the pacemaker. So if my patient has his own atrial signal and it's 0.5 millivolts, now we're going to inhibit firing to the patient's atria. If my patient has his own ventricular signal and that is 2 millivolts, we will inhibit the firing of the stimulus to the ventricle. And last but not least is the interval between the atrial spike and the ventricular spike, which is actually synergistic with your PR interval. That is the time from atrial sense or pace to ventricular pace, synonymous with the PR interval. So milliamp, spike to spike in the atria, synonymous to the P to P interval. Milliamp, spike to the ventricle, synonymous with the R to R interval. If my patient fires his own beat, and he fires his own beat in the atria, it must be higher than the millivolt signal that I've set in order to have set the sensitivity for sensing of the pacemaker. And if it fires into the ventricle has to have an impulse of around 2 millivolts in order to have the sense of the ventricular beat. Sensing the beat inhibits the pacemaker from firing until the next cycle time. Okay, so let's look at capture. So this is a beautiful strip. What you see here first is spike to P, spike to P, spike to P, and so on. So the spike to spike of the atrial pacer has to be right on time, and following the spike to spike of the atrial pacer should be a P wave. Then you have a spike to spike of the ventricular pacer. That spike to spike of the ventricular pacer, every spike should be followed by a QRS. And you can see spike to QRS, spike to QRS, spike to QRS, and so on. The spike to spike of the atria equals the spike to spike of the ventricle, just like the P to P interval equals the R to R interval. So every spike has a beat that follows it, and this is known as full capture. Sensing. The pacemaker sees and responds to the patient's intrinsic activity. So you must be in demand mode. You cannot be in asynchronous mode. Asynchronous means the pacemaker doesn't care what the patient is doing. So very hard for you to see this tiny little spike, but we know that we are paced and we have a small spike before the QRS. So spike to QRS, spike to QRS, and that signal, that termination is when the patient has his own beat. So the pacemaker resets its cadence, but the patient again has his own beat, so the pacemaker is not firing. Third beat in, and that's actually the fifth beat in, patient has his own beat and the pacemaker is inhibited. But then the patient does not have his own beat and the pacemaker spikes again, followed by a QRS, pacing spike, QRS, pacing spike, QRS. There must be true intrinsic activity in order to have sense. And that's really important. The pacemaker has to be able to sense that the patient has his own beat. With dual chamber pacemakers, they are so beautiful because they actually most significantly mimic the normal endogenous relationship of atria to ventricle. When we have AV synchrony, the atria contracts and the ventricle fills and the ventricle contracts. This improves hemodynamics in all of the patients who have heart block. And an AV sequential pacemaker or dual chamber pacemaker tracks our atrial activity. So we want to remind ourselves that we can also trigger the spike into the ventricle when the delay time of the AV interval, which is synchronous with the PR interval, is exceeded. So atrial spike to atrial beat, ventricular spike to ventricular beat, atrial contraction, no spike, time delay, the PR interval, or known on the pacemaker as AV interval, is exceeded, the ventricular spike occurs. So this is both inhibition and triggering, and it definitely improves our hemodynamics. The A to V interval allows time for the atria to contract and fill the ventricle. And this decreases the incidence of pacemaker syndrome, which actually is a dysfunction when we look at single chamber pacemakers. Okay, so remember, the AV interval is the period of time between the atrial event, either sensed P wave or atrial pace, and a paced ventricular event. The VV interval is the period of time from ventricular complex to ventricular complex. So if I fire my own ventricular beat, the VV interval is when the pacemaker will next fire from intrinsic beat to paced beat. So it's really a compensatory pause. And the VA interval is the ventricular complex till the next atrial activity. And that's called the atrial escape interval. If my patient fires his own P wave before that interval is exceeded, you will inhibit the pacemaker firing. Very complex in terms of all the terminology, but really simple. I'm going to replace your atrial impulse by an atrial spike. I'm going to replace your ventricular impulse by a ventricular spike, and those intervals are set in order to apply the most appropriate spike if there is failure of the patient to do so himself. It's really important for us to appreciate and understand. Now, something else that is incredibly informative is that when we have sensing, what we also have is what's known as a refractory period. That refractory period is just like the refractory period endogenously. Endogenously, normally, the QRS to the midpoint of the T are absolutely refractory, and during that period of time, nothing can be sensed. The relative refractory period, which is from the downside of the T wave, allows sensing, but the pacemaker will not respond. It will not fire an impulse during that relative refractory period. If it did, you indeed would go into torsade du point from an impulse fired on the downside of your T wave. Okay, so basic pacemaker timing that gets set. We set the low rate. That low rate means anything lower than that, the pacemaker is going to fire. And then we set the high rate, that upper rate limit. So that highest rate that can be achieved to still maintain AV synchrony. Beyond that, we will not be able to maintain an AV synchrony. Okay, so let's take a look at a couple of strips and identify what it is we know. Every spike, if it's an atrial pacemaker, should have a P wave. Might be hard for you to see. And every spike, if it's in the ventricle, should have a QRS following it. So what we're going to do is we're going to take a look at a couple of strips and apply the basic strategy of what we understand now. Now, typically, when we look at our pacemaker strips, we'd like to have a rhythm strip, V1 or the lead that best allows evaluation of the pacemaker. What we have to know is what pacemaker information that is. Is it transcutaneous? Is it transvenous? Or is it AV sequential? And we want to know what the program parameters and special features are, and we'd also like to have a chest x-ray to look at the placement of the pacemaking wire if we're talking about transvenous or epicardial pacing. Okay, so the first question, are there pacemaker spikes? So unipolar leads have a lead external and have a lead in the ventricle and at the tip of the ventricle. So they have basic wire formation of a positive and negative pole that is inside. Okay, forget that. Cut. Sorry. Cut. So questions to ask. First and foremost, we see a difference between a unipolar and a bipolar pacemaker, and the importance with a unipolar pacemaker is you're firing a more aggressive spike, as you can see on the EKG strip to the left. And on the EKG strip to the right, you see a bipolar spike, which is a much smaller activation because it's using two poles, negative and positive, rather than one pole, which is unipolar. So looking at the first strip on your left-hand side on the unipolar, you see spike to QRS, spike to QRS, spike to QRS, and spike to QRS. From the peak of the spike to spike, march spike 1 to spike 2, spike 2 to spike 3, spike 3 to spike 4. Now, take that spike to spike interval and match it to the tip of the QS wave, which is that downward tip, from tip to tip, tip 1 to tip 2, tip 2 to tip 3, tip 3 to tip 4, or Q wave to Q wave to Q wave to Q wave. Pacing spike must meet the R to R interval or the Q to Q interval to tell us whether or not we have full capture. We move to the EKG strip on the right of the screen. We see that small spike and a responding QRS. Okay, and we look at the spike to spike interval, spike 1 to spike 2, spike 2 to spike 3, and then correlate that to the QS peak, that little tip, tip to tip, and tip to tip. And the spike to spike should equal the Q to Q or the tip to tip of the QRS. And then the next question is to add in our atrial spike if we have an AV sequential. So you can see now that you have an atrial spike to atrial spike to atrial spike, and a P to P to P, and so on. And you have to look at all of the spikes on your strip. So spike 1 to spike 2 to spike 3 to spike 4 to spike 5 to spike 6 are all equidistant. P1 to P2 to P3 to P4 to P5 to P6 are all equal distant. So we have atrial spike to atrial capture, and that's consistent across our strip. And then we look at the spike to QRS, spike, so the ventricular spike, V spike to 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 V spike, all consistent, all regular. And then Q to Q to Q to Q to Q to Q, all regular. So I have ventricular capture, and the P wave to P wave, the atrial spike to atrial spike, the ventricular spike to ventricular spike, and the Q wave to Q wave. All those intervals are equal. So we have capture, and we don't know if we have sense because there isn't anything to sense yet. It's just capture in this strip. Here's our sense. Our sense says, does your pacemaker sense appropriately? So what we want to see is we see spike to QRS, spike to QRS, patient's own QRS occurring early, and a reset of our pacing interval. So look at spike 1 to spike 2, that's quite delayed, and spike 2 to spike 3 should have occurred about in the middle of that strip, but it didn't. So now I look and I see, oh, my patient had his own beat, that inhibited the pacemaker, and so I have reset the pacemaker cadence from the patient's own QRS to the next ventricular pacing spike. This is sense, and the pacemaker did indeed sense appropriately. So primary problems that we're going to consider for our application, which is very generic here of pacemakers, is failure to pace, meaning no impulse is fired and there's no reason for it not to have. Failure to capture, which means the impulse is fired but there isn't a responding depolarization. And failure to sense, meaning you're sensing too frequently, not a real beat, or undersensing, meaning you're not sensing frequently enough. So let's take a look at a couple of those strips. Okay, so this is normal atrial pacing, okay? And we can't really see the P wave because it's small, but what we can see is that spike to spike to spike to spike, we already know it's an atrial pacemaker, is followed by an AV interval, which mimics the PR interval. And we have our own QRS. So our assumption is that our spike is actually stimulating atrial contraction and triggering a ventricular response. Spike to spike to spike to spike to spike is right on time, and it is coherent and synchronous with R to R to R to R with a constant PR segment. So this is very important. This is normal atrial pacing, and this would be atrial paced, atrial sensed, and inhibited. Okay, so now we look at pacing spikes before the QRS, and this is a lovely strip with a spike to QRS, spike to QRS, spike to QRS. So now we're going to look at the spike to spike interval, spike 1 to spike 2, spike 2 to spike 3, spike 3 to spike 4, and so on, equaling the QS interval, or what you might call the R wave. So from ventricular to ventricular to ventricular to ventricular, looking at the tip to tip 1 and 2 to 3, 4, 5, and 6, equal our pacing spikes. So pace spikes are always followed by ventricular response. Spike to ventricular, spike to ventricular. I couldn't do it in backwards fashion, I'm so sorry. But spike to ventricular, on time, all synchronous, looks like we are capturing with every single spike. Now that QRS looks wide and bizarre because it's basically generated from the right ventricle and it doesn't follow normal pathways. So what we see is actually a left bundle branch block visualization. But right now we're just looking at V1, so everything is going to the left, nothing's coming to the right, impulse to the left in a left bundle branch block pattern. Now we have normal AV pacing. So we can see that we have an atrial spike to atrial spike to atrial spike to atrial spike to atrial spike. And then we have a ventricular spike to ventricular spike to ventricular spike, and so on. We don't actually see the P wave, but our spike to spike interval equals from the atria and the ventricle and the ventricular response. So atrial spike, A spike to A spike to A spike to A spike equals V spike to V spike to V spike to V spike equals R to R to R to R. Even though we don't have an R wave, we're going to call it the R wave so we're not too confused. We could also call it Q to Q to Q to Q, or tip to tip to tip to tip. And the normal AV interval, that's atrial spike to ventricular spike, is constant. So what we've looked at is the same thing we do with all EKGs, except instead of P to P and R to R, we're looking at spike to spike. A spike to A spike, V spike to V spike, the A spike to V spike, which is the AV interval, and the corresponding ventricular response. Everybody got it? Probably so, and I'm so glad. Okay, so this tells us that we have a DDD. And this, if we knew that that's what it was set to, it doesn't matter. We are spiking our ventricle, and the ventricle is paced at the atrial rate. So DDD means how many chambers are paced? Right, dual. How many chambers are sensed? Right, dual. And what's the property? Are you inhibited and triggered? Yes, if it's D, you're inhibited and triggered. Dual, DDD. Dual chambers paced, dual chamber sensed, and the dual response triggered and inhibited. And in this patient, they have their own P wave, and you can see that P wave has a long PR interval, but the patient's own P wave is triggering the ventricular spike. And if that time interval is longer than your programmed AV interval, which is your PR interval, the ventricular pacemaker fires, and that's what's happening here. Your ventricular pacemaker is firing. Now, if you didn't know it was a DDD, you might have said it was a VVI, meaning ventricle paced, ventricle sensed, and inhibited when patient's own beat was seen. VVI will appear very much like DDD if the atria is actually working, and in this case, it could either be DDD or VVI. Okay, now we look at atrial non-capture. Okay, now what I'm going to tell you here is I'm not certain that this is atrial non-capture. I actually think it is atrial capture with a P wave that can't be seen. So all we're looking at here is this spike to spike to spike to spike interval of the atria, and then the spike to spike to spike to spike interval of the ventricle. And I'm looking at the constancy of the AV interval. So I actually think that the atria is being actually activated, and we just aren't able to see the atrial impulse. So my advice in this case is try another lead to see if you can see a P wave following the atrial spike. It is possible that you are not stimulating the atria, but you can't make that decision from one strip. You must have a 12-lead EKG so that you can look at P waves in lead 2 as well as in V1, where you see the best visualization of your P wave. Okay, ventricular non-capture. Now this one is really important. So I'm looking at spike to spike interval, spike 1 to spike 2, spike 2 to spike 3, spike 3 to spike 4, spike 4 to spike 5. And what we're actually seeing is that we do not have ventricular response after every spike. So the first beat that you see, spike to QRS, is capture. And then you never have capture again. You never have capture again. And what that means is that you have spikes that are on time. That rate equals the rate you set on your pacemaker. So V spike to V spike to V spike to V spike equals the rate that was set on your pacemaker. But you are not capturing the ventricle. Impulse is sent, not captured by the ventricle. Therefore, no QRS is following the pacer spike. Now, one of the big concerns here is now you have an inadequate heart rate to maintain homeostasis and good blood flow dynamic. So oftentimes when you have failure to capture, you have to consider that your wire may have come out of place, that you may have ischemia around the wire tip, you might have electrolyte imbalance, but the very important thing that we're going to do in the moment is we're going to turn up the electrical signal, that's the MA, to try to capture the ventricle. So with the permission of my physician, hopefully my physician or APP is in the room, we'll turn up the MA to try to capture the ventricle by using a bigger signal. So we're going to turn all the way up to 20, and that's the highest we'll ever go. At 20, can we capture the ventricle? And then we're going to turn down slowly until we see failure to capture, and we step just above failure to capture in order to capture the ventricle. Now, capturing the ventricle means spike to spike to spike is absolutely on time, but we don't have a ventricular response. So first, before you ever say non-capture, you must be sure spike to spike to spike equals the rate that you set on your pacemaker. So, failure to capture. Insufficient energy delivered by the pacer, turn up the MA. It may be that your battery is low. Look at your pacemaker, you'll get a signal that says battery is low. Now you may have dislodged the wire, it could be loose, there could be fibrotic tissue around it, the electrode could be fractured. There's nothing you can do about that except replace the pacemaker. And electrolyte abnormalities, metabolic acidosis, profound hypoxemia, and hypokalemia. But this is really dangerous. When you have non-capture, your patient's heart now is decrease in depolarization, which means no contractions associated with any spike, because you must have a corresponding depolarization to have a contraction. And the danger here is life-threatening low cardiac output. So remember, first we call and then we increase the MA. We increase the MA to try to capture the heart, and that's going to give us some time to figure out what else is going on for the patient. First thing we're going to do is call, ask permission to increase the MA, or have the physician or APP with us and have them increase the MA, but you must increase the MA with failure to capture. Okay, so remember what I said before, always look at least 2 views, change your electrodes, check your connections, make sure you're all connected, increase your MA, change your battery, change the cables, and ultimately change the pacemaker. All right, so now we look at some other things with abnormal pacing. This is atrial undersensing. So atrial pacing spikes occur whether or not you have a P wave. That's undersensing. So you can see you have a P wave, you have an atrial spike, you have a ventricular spike. You have an atrial spike and a ventricular spike. You have a P wave and you have an atrial spike, and then you have a ventricular spike. You have a P wave and then you have a ventricular spike. So that middle beat where the patient had his own P wave, you can see where it says P wave from patient, which is intrinsic. That's your patient's own P wave. That P wave should have triggered a ventricular spike. But because the atrial pacemaker wasn't sensed, you still fired an atrial spike, which led to a delay in the ventricular stimulation. From the patient's own P wave, patient's intrinsic, you should have had the AV interval, which is where you see the atrial spike, but that should have been a ventricular spike. So the patient's own P wave triggered the ventricular component of the pacemaker. And that would have been a very, very important perspective. So on beat 1, you see that you have failure to sense the atrial beat, because it should have then been a ventricular spike and a QRS, but instead you had an atrial spike. On beat 2, you had a normal atrial spike, normal AV interval, ventricular beat, ventricular spike, and ventricular beat. On number 3, you had patient's own P wave, but you still had an atrial spike, an AV interval, ventricular spike, ventricular capture. On the 4th one, you had an appropriate atrial spike, ventricular capture. On the 5th one, your patient had his own atrial beat, but he failed to sense the atrial beat, and the atrial pacemaker still fired, and you have a normal AV interval and a ventricular spike. This is atrial undersensing. So now let's look at ventricular undersensing. So you can see, looking at the strip, that you have a spike, and then you have the patient's own QRS, and then you have a spike, and then you have another spike, and you have your patient's own QRS, and then another spike. So there are 2 problems here that are really important. First of all, not sensing the patient's own rhythm. So you see the patient's own intrinsic QRS followed by a spike, and that pacemaker sent an impulse anyway. But in addition to that, we also see that we have the first beat on this EKG, or the first electrical visual, is a spike. It's not physiologic. It's so thin, it can't be physiologic. So you have a spike not followed by a QRS. Then you have a QRS, and you have another spike, and that fell on the T wave. Then you have a spike, and you have your patient's own intrinsic QRS, and another spike. So in reality, this is not undersensing. It is undersensing and failure to capture. Now, when you have failure to sense, pacemaker just isn't sense enough to the patient's intrinsic activity. So the window, it's a threshold window. The lower the window, the more sensitive. The higher the window, the less sensitive. We need to make our window more sensitive. You also have insufficient myocardial voltage, so you need to turn up your MA, because the MA is the electrical activation. The MV, remember, is the sensitivity, and the MA is electrical activation. Might be dislodged, loose, fibrotic, might have a fractured electrode, could have electrolyte abnormalities, low battery, or the pacemaker or the cable are not functional. So again, we look at failure to sense here, and you can see this failure to sense. The danger is potential for the pacing spike to land on the T wave. So in the very same one, we have an R on T phenomena, and the patient goes into VFib. Oh my God, that's really bad news. So actually, one of the things I would do would be to increase the MA, try to recapture the heart, and then I would make the pacemaker more sensitive by reducing the requirement of the millivolt signal of the patient, so that the pacemaker actually sees the patient's own endogenous heart rate. So, failure to sense, always look at 2 leads, typically lead 2 in V1, change your electrodes, change your connections, increase your pacemaker sensitivity. So that means we're going to change that millivolt signal, change your cables, your battery, your pacemaker, and check your patient's electrolytes. Okay, very, very important. When you wish to assess your patient's rhythm, I have many cardiologists and surgeons who do this. They just come in and they unplug the cables. That is not the right way to check your patient's own rhythm. Basically, what you can do is either pause your pacemaker or turn the pacemaker rate down. So just like having an apnea setting on the ventilator where you will not allow a patient to breathe less than 8 times a minute, turn your pacemaker rate down to around 30 or 40 so that there is always a paced rhythm if the patient has no rhythm at all. And you can see here that basically they pause the pacemaker or they unplug the cables intentionally and the patient had no rhythm. So just turn the rate down and then turn it back up again. Okay, so let's look at a couple of practice strips. Remember, this was a quick overview of pacemaker. So look at your spike to spike interval, spike 1 to spike 2, spike 2 to spike 3, spike 3 to 4, and so on. Look at your spike to spike interval to your R to R interval. And in the beginning, you might have said, oh, look, it's a ventricular pacemaker, except the response always has to follow immediately, so you have a delay, and that delay is constant. That delay is an AV interval. So this is an atrial pacemaker with atrial sensing and inhibition if the patient's own P wave is seen. Now, you might not have been able to say it's an AAI, you might have said it's an AOO, meaning no sense and no component required without sensing. We don't know that. Only way we know is that this is an atrial spike with a constant AV interval, constant spike to R to R, but we're just not seeing a P wave. Take a look at this one. Now, you might not even think this was a paced beat, but indeed it is. So let's think about what kind of a pacemaker that might be. If we're seeing a spike and we're looking at that non-physiologic spike, what we're going to see is this patient doesn't have pacing. This patient has a normal sinus rhythm with no pacing. So he might have a backup demand rate set if the heart rate falls below a certain rate, because you don't see a spike. You might have wanted it to be a spike because it was narrow, but it isn't a spike. It's the patient's own sinus tachycardia and a normal rate, normal rhythm, normal sinus rhythm, but really a sinus tachycardia. And there's no pacing seen here. Okay, what about practice strip number 3? Okay, so spike to QRS, 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 spike to QRS. But your patient has his own beat, and you can see that in third one in and sixth one in, the patient has his own beat. What this is a dual chamber atrial and ventricular pacer. So first spike, spikes to the atria and the ventricle responds. First spike, spikes to the atria, the ventricle responds. The next one is a spike to the ventricle, and we have ventricular failure to sense. Our patient has his own beat, and what's happened to this patient is that he has a ventricular failure to sense. So looking at your spike to spike to spike to spike interval, what you're seeing on that third beat in, take a look at that third beat in. It's very complicated, right? That third beat in is the patient's own ventricular beat that did not wait for the AV interval, and immediately following that beat, you can see that little tiny dip downwards. That's your ventricular pacer, and it fired after the patient had his own beat. It did that again on the sixth beat, fired after the patient had his own beat, and it almost fired on the T wave. So the possibility for VF is very high here. So again, look at the first cycle, spike to atria and ventricular trigger. Spike to atria and ventricular trigger. So in those two cases, the ventricular pacing spike can't be seen. Then you see spike to the atria and the patient's own ventricular response with a ventricular spike immediately following, and that's between the QRS and the T wave. That's occurring right in the ST segment. And then spike to ventricular with a constant AV interval. This is a DDD. We should be pacing both the atria and the ventricles, but we have ventricular failure to sense. So now we need to make the pacemaker more sensitive by decreasing the MV signal, and we may see improvement immediately. Okay, Practice strip number 4. Take a look. Do you see a spike? Spike 1 to spike 2, spike 2 to spike 3, spike 3 to spike 4, spike 4 to spike 5, spike 5 to spike 6. And every one of them is followed immediately by a QRS. We're going to say that this is a ventricular pacemaker and it's in VVI, but we wouldn't know that without looking at the setup on the pacemaker because every spike has a QRS. So unless you have your own endogenous beat, it's not available for us to see whether or not the pacemaker can sense. We only know if it can sense when the patient has his own beat. So we look at this and we say this is a ventricular spike to a ventricular response. Every spike has a ventricular response. This is VVI and it's normal ventricular pacing. Okay, ooh, let's take a look at this one. Ooh, this one is really most interesting, right? You see the first one with the spike to QRS, then you see a spike, then you see a spike, then you see a QRS, then you see a spike, then you see a QRS, and then you see a spike. Uh-oh. So our atria is triggering the ventricular spike. So you see a P wave before the spike, P wave before the spike, P wave before the spike, then a spike with nothing, and then the patient's own QRS, and then a P wave before the spike. So what do you think this is? Do you think this is failure to sense? Do you think it's failure to capture? Okay. This is a DDD pacemaker, dual chamber pace, dual chamber sense, and dual inhibition and trigger. But this is failure to capture both the atria and the ventricles. The P waves we see are our patient's own intrinsic P wave. But what we have is a failure of capture. So we will increase both our atrial and ventricular MA. Remember, MA is the signal we send to the patient to stimulate the heart. I want to see more effective atrial stimulation. You can see at that second beat in, you've got a ventricular spike, which was triggered by the patient's own atrial beat, but no QRS following. And now we see, and secondly, we see that atrial pacemaker spike, and then we see that little blip. You might have thought that was a P wave, but it's way too long after the pacer spike. So I'm going to increase the MA on both my ventricular and atrial activation because I need a higher level of activation to capture the atria and the ventricle. Okay, so going to the second beat in, you see first the upright spike, the upright to the upright to the upright to the upright to the upright, spike to spike to spike to spike. So that's a spike, a spike, a spike, a spike, a spike. And then I have an AV interval and I have a V spike, V spike, V spike, V spike, and V spike. Gorgeous. Fabulous. So what do you know you have? You know you've got a dual chamber pacemaker, and you're going to assume that it's dual chambers pace, dual chamber sense, and dual chamber activation. But it's all beautiful because it's normal. So A spike, V spike, and a perfectly appropriate AV interval, DDD. Dual chamber paced, dual chamber sensed, and dual chamber function. And again, I'm going to validate that by looking at what's been set on my pacemaker. Okay, practice strip number 7. We might have seen this before, but this is really beautiful. So looking at the second beat in, spike to QRS, spike to QRS, spike to QRS, marching all the way across. So V spike to V spike to V spike to V spike, QRS to QRS to QRS to QRS. The rates are equal. That means that every spike has a QRS. And so what we can say that we know for certain is that we have ventricular pacing. And we assume that we have ventricular pacing with ventricular sense with an inhibition. So that's a normal ventricular pacing with a normal atrial sense. Note that the P wave is occurring without an atrial pacer spike. So we're assuming that our patient has his own atrial endogenous capabilities. P wave to V spike, P wave to V spike, P wave to V spike. V spike to QRS, V spike to QRS, V spike to QRS. This is a VVI pacemaker, and we've got capture. Houston, we've got capture. Practice strip 8. Again, looks like something we may have seen before. we can see that we have these upright spikes. That's atrial spike 1 to spike 2 to spike 3 to spike 4 to spike 5 and so on. Then we have a constant AV interval. And then we have a ventricular spike, spike to spike, V spike to V spike to V spike to V spike. Atrial spike to ventricular spike, constant. Ventricular spike to QRS, constant. So we know that we have a DDD. Now we might have some atrial failure to sense, but we have a normal ventricular pacing. So we might have a failure to sense because if we look at the very beginning, we see a P wave followed by that spike. And that spike should have occurred or should not have occurred, and we should have had a normal AV interval. And on that very first beat, you see that P wave followed by an atrial spike. That's a failure to sense the atrial spike, and the P wave of the patient should have encouraged the ventricular spike. But you have a very, very long P to ventricular interval, and you have the atrial beat firing. So what we need to do is make our atrial pacer more sensitive to the patient's own P wave. So we're going to decrease the millivolt. That means we're going to lower the threshold so that a little beat firing gets seen by that threshold, and that's what our sensitivity is. Practice strip 9. Ha, ha, ha. This is pretty awful. So first beat, spike to QRS. Second beat, spike to QRS. Third beat, spike to QRS. Fourth beat, spike to QRS. And then nothing. Nothing, 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 nothing for a little bit. And then you see a spike to QRS. Okay, so what do we think that is? That's a ventricular pacemaker that has oversensed. It sensed the P waves and saw that activity as a ventricular beat. That pacemaker is way too sensitive. He cries at every sad movie. That pacemaker is too sensitive. Your P wave got sensed by the pacemaker as a ventricular response. So what you have to do is make your pacemaker less sensitive. You're going to increase that millivolt signal. That means that those little bumps that the pacemaker is sensing, their threshold is too low. So I'm going to increase my millivolts so that the little bumps don't get sensed as ventricular beats. We have a failure to fire because we are over sensing the P waves as a ventricular response. Okay, so I want to make sure we appreciate this was a very quick overview of pacemakers. I want to make sure that we know that this does not supplant your need to really understand pacemaker therapy. And in your little book that I've put up in the folder of miscellaneous, I've asked you to go to the Medtronic Academy and take all of the pacemaker classes there, take the test, give me the certificate. But always know what mode your pacemaker is set at. You look at the pacemaker for that. Use MA necessary to capture. And don't use any more milliamperage than you need to capture the heart. Look for the spike and measure spike to spike. Then measure beat to beat. So atrial spike to atrial spike should equal P to P, if you can see it. Ventricular spike to ventricular spike should equal QRS, if you can see it, which you should be able to. And it may be a very abnormal looking depolarization. If the pacer fires and there's no corresponding activation and it's right on time, and there are no endogenous beats, that's a failure to capture. If the patient's own beat fires and there's no resetting of the cadence, that's a failure to sense. So look for spikes and response, increase the MA for failure to capture, increase sensitivity, which is decreasing the MV for failure to sense. Those are our salient points today for pacemaker activity. And please, look at the Medtronic Academy and take the course on pacemakers. This was just to remind you, you need to know the mode, you need to know the milliamps, and you need to understand the sensitivity. And remember, last but not least, if it's an AV sequential pacemaker, you need to know the AV interval, which mimics the PR interval. Thank you so very, very much. I'm so happy to have joined you today, and I look forward to seeing you again in the next set of cardiac rhythms.